Now, before you start attending this question, let's have a basic overview of what exactly is a polyp. It will help us to understand these questions better. देखो, what exactly is a polyp? Polyp is just a proliferation of mucosa that we all know. Polyps usually are in the intestine, but as you all know, polyp can also be in the nasal mucosa, it can be in the ear mucosa, can be anywhere. So what basically is a polyp? Polyp by definition is a proliferation of mucosa, that's it. Now see, whenever you talk about a polyp, the polyp is a proliferation of mucosa, that we understood. If you talk about a colorectal polyps, this is defined or differentiated or classified as classification of such type of polyp is usually done on the basis of three types. It can be benign or can be malignant. Okay. In the benign polyp, remember a simple mnemonic HHI. What is it? HHI means it can be hamartomatous, it can be hyperplastic, or it can be inflammatory. It can be inflammatory. The three types of benign polyp. Again remember, hamartomatous, hyperplastic, inflammatory. I'll talk about all of these. In malignant, there is a name called as Adenomatous polyp. Okay, it's an Adenomatous polyp. Clear? Now, when you look at the hamartomatous polyp, this one, see, the hyperplastic polyp is usually due to the proliferation of the goblet cells. Inflammatory example is, this example is solitary rectal ulcer. Solitary rectal ulcers. They often bleed a lot. Okay. When you talk about the hamartomatous polyp, this polyp is then again of two types. It can be, this can be either a juvenile polyp, or it can be a P-U-T-Z, Peutz Jeghers polyp. Clear है? It can either be a juvenile polyp or can be a Peutz Jeghers polyp. Now, before I show you these images, let's understand the basic things about them. देखो, when you say a polyp like these two, and I call it hamartomatous. What is hamartoma? Remember hamara tissue. What is hamartomatous? Hamar tissue. That means it's a abnormal tissue at its normal location. Abnormal tissue. Because it's abnormal tissue, even though it's a benign, it has a malignant potential. It doesn't mean it's malignant. It's a benign polyp, but has a malignant potential. Got the point? It's benign polyp, however. Then, juvenile polyp is seen in less than 5 years of age. Okay. The main site is rectum. Okay. And most clinical features often presents with rectal bleeds. Peutz Jeghers polyp, usual age is 5 to 15 years. Main site is jejunum, and it often presents with abdominal pain. Now remember one thing, when you call them a polyp, that means there are few occasional polyps here and there, sporadic polyps. Often these polyps are seen with syndromes. And when they are seen with syndromes, they have mutations, obviously. Mutation with juvenile polyp, remember, is called as SMAD, SMAD4. And the mutation syndromes are called as juvenile polyposis syndrome. The Peutz Jeghers polyp, when these come with the mutations, the mutation here is STK11. Gene name is STK11. Okay, STK11. And they come with Peutz Jeghers syndrome. Now, what happens in the juvenile polyposis syndrome is there are around say 50 to 80 or 100 autosomal dominant condition in which you see these polyps. But in Peutz Jeghers syndrome, along with the Peutz Jeghers polyp, which I will just show you after this, apart from those polyps, they often are associated with some condition like the mucocutaneous pigmentation, along with the increased risk of interception. Increased risk of interception is always there in the Peutz Jeghers polyp. Okay. Now, first I will show you some gross morphological images. We'll then see the microscopic images. First, have a small revision of this. Polyps can be benign or malignant. Benign, it is 3 types, HHI. Among the first H, hamartomatous, there are 2 types, Pews-Jaeger polyp, sorry, the juvenile polyp and the Pews-Jaeger polyp. These polyps are benign, but when seen with mutations and with syndromes, they become a predominantly malignant polyp. However, they predominantly are benign. Number 1, they have a risk of malignancy, number 1. Secondly, when with syndromes, they often are malignant. When with syndromes, they often are malignant. See the conditions. This is actually a polyp. This is a stocked polyp, and hence we will call it as pedunculated polyp, pedunculated. And this is a sessile polyp because it does not have any peduncle. Okay, so this one is a sessile polyp and this one is a pedunculated polyp. Clear? This is how they look like in the colonoscopic view. These are all the polyps. Look at this colonoscopic view. Just go inside this and you see this beautiful looking polyp. Beautiful for you, not for the patient. Okay. Now see, these polyps, when you look at the microscopically finding, the 2 findings that I will just show you first, look at these 2. They are different. Why? In the juvenile polyp, this is a polyp. Exactly what happens, see, suppose there is a mucosa like this. This is a polyp, how it looks like. Now, if this is a polyp, they will show you big glands like this, large glands. These are glands like this. The juvenile polyp will show you abnormal, large, dilated glands. Abnormal, large, dilated glands are the juvenile polyp. In the Pews-Jaeger polyp, these are having not a big polyp like that, but they have branches like a tree, like this. Look at this branch. If this is one branch, this branch is here. Look at this branch. In the branch, what you will observe is, look carefully, you will be able to see this dark muscle layer. Look, this dark muscle layer, this dark muscle layer. This dark is the muscle layer. Surprisingly, polyp is a proliferation of mucosa. What is muscle doing there? Remember, it is hamartomata. It is hamartomatous polyp. It can show you some abnormal tissues. So what is happening? Actually, there is abnormal proliferation of glands. So where are the glands? These white area are all the glands. These white are all the glands. So this white area, these are all the glands. Abnormal proliferation of glands plus muscle in arborizing pattern. Okay, in arborizing pattern. These are referred to as the juvenile polyps. Sorry, these are called as Pews-Jaeger polyp. Pews-Jaeger polyp. Okay, so what is the difference? In juvenile polyp, you see large glands. Look at these large glands here. One gland, second gland, third gland, fourth gland, and this whole thing is a mucosal layer. So this whole thing is called as juvenile polyp. And when you look at a Pews-Jaeger polyp, look at one tree branch, the second tree branch. So this is one more branch like this, and in the branch there is a muscle layer. I'm writing as M, and the glands layer, there's G. So glands and muscle along with lamina propria, muscle layer, they all will in a projection like a tree. It is called as the Pews-Jaeger polyp. Pews-Jaeger polyp. So actually, how do they look like? I'll show you the better images also. Dekho, look at this one. In this image, Dekho, look at this one. In this image, you can see this tree, and this polyp is looking like a branch of a tree. Look at this muscle layer here, this muscle layer here, and the glands here. So glands and muscle in a tree-like arrangement, it is called as bolo Pews-Jaeger polyp. But if you look at a polyp, something like, sorry, this one, this is showing you big glands, and therefore this one is juvenile polyp. This is one branch, second branch, and this one is Pews-Jaeger polyp. This one is juvenile polyp. Clear? Now, if you come back to our discussion, see, a polyp, if it shows a finding something like this, it is a mucocutaneous pigmentation. Mucocutaneous pigmentation. What is this with? It's a Pews-Jaeger polyp. It's seen with a Pews-Jaeger polyp. Pews-Jaeger polyp. So before we move to the next type of polyp, let's solve this question. This actually is a Pews-Jaeger polyp, right? It's a Pews-Jaeger polyp. Why? Look at the branch of a tree. Okay, and you look at this muscle layer. There's a muscle layer here. Clear? Now see, autosomal dominant inheritance, that's true. Multiple GI hamartomatous polyp with mucocutaneous pigmentation seen, that's true. That also is true. Now see, 50% shows SMAD4. No, they show what? STK11. This is false. Fourth is histological examination shows characteristic arborizing pattern. Exactly, arborizing means tree-like. What does it mean? Tree-like, branch of a tree with smooth muscle, lamina propria and glands lined by normal appearing intestinal epithelium. Exactly, that is how this entire polyp look like. What is the polyp name? Peutz-Jeghers polyp. Syndrome will be called as Peutz-Jeghers syndrome, and juvenile syndrome is called as juvenile polyposis syndrome. Both of them polyps wise is benign. Do they have malignant potential? Yes. And with syndromes, definitely yes. Okay? This is all about the initial benign type of polyp. Let's now move to the next type, which is adenomatous polyp. What about this? So we have a next question here. The following statements are true regarding colonic polyposis shown below, except. Look at this huge number of polyps here. These are all the colonic polyposis. They often are referred to as FAP. Now, why FAP? देखो, what happens if there is an adenomatous polyp and that adenomatous polyp has a mutation called as APC gene, it becomes what? It becomes a FAP. Let's understand the FAP now. देखो, adenomatous polyp. Adenomatous polyp. Remember, why am I calling this malignant polyp? Because in microscopy they show dysplasia. They may also show anaplasia, plus minus anaplasia, but because they always show dysplasia, it is malignant by nature. Malignant by nature. The morphology wise, in the gross morphology, they will show you, suppose this is a mucosal surface. Sometimes the polyps are shaped like this, sessile polyp obviously, but the glands are like tubular, like tubes, like this. Now, why am I wearing this tube? Because it's a cut section, right? So, in a complete view, this tube would be something like this. Now, you are cutting it from here, and this is what you are seeing here, and hence called as tubular polyp. Sometimes the polyps are something like this, like a villi, hence called as villus polyp. And sometimes there is a combination of both of them. There is a tubular also and villi also, tube also and villi also, and hence the name tubulo-villus polyp. Hence the name tubulo-villus polyp. Okay, tubulo-villus polyp. Now, first MCQ is, among them which is most invasive? The most invasive among these three is the villus. This is most invasive. However, let me tell you, the most important criteria for malignancy is size. The most important criteria for malignancy is size, not the histopathology, not the histopath. The most important is size, not the histopath. This you must know. Okay, without, if you look at the same sized polyp, the maximum invasive is of villus. But again, if you see a villus polyp of 2 cm and a villus polyp 5 cm, which is more dangerous? 5 cm is more dangerous. Clear till now? Okay. Now you look, come back to this one. See this one, the first one. What is it? It's like a tube. Look at the huge number of tubular polyps, like this tube, round glands. These are the tubulus polyp. The second one is villus. See how villus? 1, 2, 3. Look at a huge number of villus polyp. They are villus polyp. Correct? And look at the third one. It's a tubulovillus. That means there is a villi and there's a tube inside this. And it's called tubulovillus polyp. It's a tubulovillus polyp. Look at this, very clear now. Look at the exact number of tubes here, round tubes, nothing. This whole thing is a polyp. In second one, look at the villus. Do you see any tubes? No, there's no tube like that. Can you see any glands like this? Not at all. Because not able to see the glands like this, we'll call it simply a villus polyp. It's a villi, round like finger like. Look at this finger, villi. This is a tubulovillus polyp. It's a tubulovillus polyp. Clear? Now, what happens sometimes, guys, along with the morphology, sometimes these polyps have a mutation, and mutation is of FAP gene. Sometimes, let's remove this now, sometimes the mutation you see is of APC gene, which is on 5q21, chromosome number 5, long arm 21. When you see this, it now becomes a FAP. What is FAP? autosomal dominant condition called as familial adenomatous polyp, become familial adenomatous polyp. Now, the number of polyp more than 100, it is sure short malignant. Number, if the number of this polyp is more than 100, it is sure short malignant, and therefore the patient should be offered colectomy. The patient should be offered colectomy. In fact, nowadays there is screening going on, and the screening looks for the APC gene mutation. If a patient has a APC gene mutation, he usually will develop the polyp in his next few ages, and therefore a good amount of screening is required at 6 month or 1 year interval for looking for development of such polyps. If the polyp is more than 100, like look at this image, huge number of polyp, must be more than 100, the patient has been offered colectomy, and therefore you have tried to salvage the patient's life. Okay. Now, always the patient doesn't have APC gene mutation. Sometimes the patients have another mutations, sometimes I will say just rarely they have a mutation called as DNA repair gene, DNA repair gene mutation, DNA repair gene mutation. This mutation has a name MSH or MLH or MSI. These all are the microsatellite hypermethylation, okay, microsatellite instability. These all are the genes which have a instability of the satellite region. And why it is so? Because satellite region, if you remember, has telomerase, and if the telomerase is overactivated, they can cause limitless replication potential. So this is another gene which is seen there, but usually the DNA repair gene mutation in the adenomatous polyp, they are called as attenuated FAP. Often they are referred to as attenuated FAP, DNA repair gene having attenuated FAP. In this condition, the number of the polyps in attenuated FAP, the number of polyp is not 100, it is around 40 to 60. It is around 40 to 60. It is around 40 to 60. Okay? Now when we say this as FAP, FAP has two types of syndromes. One is called as Turcot syndrome, and one is called as Gardner syndrome. Okay, so just forget about this attenuated FAP right now. If you come back to this normal usual FAP, the usual FAP has two types of polyps. There are two types of syndromes. One is called as Turcot syndrome, and one is called as Gardner syndrome. I'll come back to these two syndromes again. I'll come back again to these syndromes. Now, what happens is, as you understand, suppose there's a normal mucosa. There's a normal mucosa. The normal mucosa is progressing to a polyp. How will that occur? See, it is called as adenoma-carcinoma sequence. Adenoma-carcinoma sequence. What happens is, a normal mucosa, it will progress to an adenoma, right? Adenoma in sequence wise will be early, will then move to intermediate, intermediate risk, will then move to high risk adenoma, or you can say late adenoma, and finally this adenoma will lead to what? Will lead to a carcinoma, and hence called as adenoma-carcinoma sequence, What are the mutations you see there? As I told you, the first mutation to occur will always be the APC, and APC has a, if you remember, APC is what? It's a tumor suppressor gene, and has a proto-oncogene called as beta-catenin. So APC or beta-catenin, this APC or beta-catenin, why does it have? You may wonder, every person will not have this tumor, some will have this, right? So what happens? One of the mutation is at birth only, germline, and second one is a somatic mutation, that is acquired mutation. So what happens? The germline mutation is there, and then there is a second allele mutation which can occur after birth. So this APC and beta-catenin occurs here also and here also, APC, beta-catenin, beta catenin, it is progressing to beta catenin. This causes both early and causes intermediate sequence, intermediate adenomas. Because then what happens, there is a mutation called as KRAS and the BRAF. These two are what? They are oncogenic mutations. They are oncogenic mutations. Oncogene mutations. They are oncogene mutations. After this, two things can happen. Two things can happen. Number one, if there is a normal P53, remember the P53? Policeman, guardian. So P53, if there is a P53 normal, I'll call it wild type, then the adenoma will not go to carcinoma. It becomes senescence. It becomes senescence. But if there is a P53 mutation, it will lead to what? It will lead to carcinoma. It will then lead to carcinoma. It will then lead to carcinoma. Remember, this carcinoma, it will keep on progressing because this carcinoma has a multiple telomerase activation called as those MSI gene. MSI, microsatellite instability, will obviously occur in this carcinoma to maintain the tumor, So the sequence, as you see, the sequence, I used to remember this as ABC. I used to never forget this also. ABC, APC, beta catenin, ABC. This is what? It's a tumor suppressor gene. Then what happens? An oncogene, which is BRAF and RAS. And finally, you all know who is the policeman? P53. Simple way to remember. ABC, then KRAS, BRAF, and there is a P53 mutation. This is called as adenoma-carcinoma. It's called as adenoma-carcinoma sequence. First adenoma is normal mucosa. It then becomes early adenoma, intermediate adenoma, and then becomes a late adenoma. Finally, can lead to carcinoma depending upon the presence or the absence of this guardian policeman P53. It's called as adenoma-carcinoma sequence. Okay, let's come back to this. Dekho. Now, if you look at this question here, look at the question. All the following statements are true regarding colonic polyposis, except, remember, except is a question. This is a huge amount of polyps here. Number one, FAP without APC gene has another target MYH. Is that true? What do you call this? Attenuated FAP. Attenuated FAP. True. Clear? Second, untreated case develops malignancy. Definitely true. What is the treatment? Colectomy. Okay? Third, thoracic colectomy prevents the risk of development of cancer in other organs as well. Definitely yes. What happens is a unique thing. It is a unique thing that you must know, that when there is a removal of colon, then this tumor cannot even metastasize to other areas. In fact, removal of the tumor somehow decreases the proliferation of the gene and the cells in other organs as well. So in fact, it decreases the occurrence of the tumor even at ovaries, at lungs. So this is very unique about the removal of the tumor. Therefore, prophylactic colectomy definitely prevents the occurrence of tumor at other organs. Don't see it as false, it's actually true. And remember, Gardner syndrome encompasses a FAP with brain tumor and medulloblastoma. No, no. This, remember two things. Whenever you see a patient with FAP, with A, if you see glioblastoma and medulloblastoma, it is Turcot syndrome. Turcot syndrome. And if you see a patient of the FAP with multiple osteomas of the bone, desmoid tumor, along with unerupted teeth, these all becomes what? They become Gardner syndrome. Now, I understand these two are very confusing. So, I used to remember this as only one of them, Gardner. So, there was a gardener working in my garden. So, he did not have the teeth that is erupted. So, often he used to keep his mouth closed. Unerupted teeth, desmoid tumor, and multiple osteomas of the bone. It is Gardner syndrome. Okay, Gardner have teeth. Turcot has nothing to do with teeth. Okay, this is how you can remember. Turcot syndrome have brain tumors. Okay, Turcot has brain tumors. Gardner who works in your garden, he will have teeth. but sadly his teeth is not erupted. You can remember Gardner syndrome, they don't have the unerupted teeth, they have unerupted teeth, they have desmoid tumors, which what is desmoid tumor? It's a smooth muscle tumor which is of fibroblasts, okay. And there is a osteomas. What the osteoma? It's a bone tumor which can occur in skull also, okay, it can occur in skull, it can occur in the bones. Osteomas of the skull and bones are often seen in the Gardner syndrome. So, this is a very brief basic view of the polyps. Remember, polyp is a bit important topic, surgical topic though, but it's very important. So, how to just revise topic? First revise the colorectal polyp, benign and malignant. Benign mein HHI, okay. Then there is a juvenile polyp and pure sugar polyp. These two are what? Hamartomatous polyp. Polyps look like this, can either be sessile or can be pedunculated, okay. And this is how they look in a colonoscopic view. If you look at the juvenile polyp, they have large glands. If you look at the juvenile pure sugar polyp, they will have what? These are what? They are arborizing pattern, and inside them they will have the dark pink area which are the muscle areas and the glands. Arborizing pattern, remember this. And then you look at the three types of Adenomatous polyp: tubular, villous and tubulovillous. Most invasive, villous, but most important criteria for malignancy, size. This is how they look like, okay. Sometimes they have a APC gene, then it's called as FAP. Two syndromes, remember now, it becomes clear, Turcot and Gardner, Turcot and Gardner. And they have sometimes a mutation of other gene called as DNA repair gene, which is MSH, MLH or the MSI, attenuated FAP is the name. And then there is a Adenoma-carcinoma sequence. How to remember? Remember, just close your eyes and say A, B, C, APC, beta catenin, then oncogene, BRAF, KRAS, and finally the policeman. Who is a policeman? P53. If present, no carcinoma. If absent, definitely carcinoma. And that carcinoma has multiple telomerase activation and that can lead to a definite evidence of adenocarcinoma of the intestine. This is how you understand in simple words what is a colorectal carcinoma, colorectal polyps and everything else. Okay guys?